Signs in thoracic imaging. I have no financial disclosures relevant to this talk. I'd like to thank my colleague Dr. Heinemann for generous use of material for this lecture. Our objectives and my outline for the talk are to discuss some signs that are useful for localization of abnormalities on chest radiographs. Then we will discuss some signs that suggest a specific diagnosis. And finally, we will discuss some signs that suggest a limited set of differential diagnostic possibilities. Let's start with some signs useful for localization of abnormalities on chest radiographs. In this example, there is a lobulated mass along the left upper mediastinal border. Note that I can clearly define the silhouette of the left hilar vessels through this mass. This is an example of the so-called Hilum overlay sign. And what this means is that the mass must be situated either anterior or posterior to the left hilar structures. Notice that in this example, the inferior border of the mass merges imperceptibly with the left heart border, indicating an anterior location, and thus this is likely either an anterior mediastinal mass or perhaps somewhat less likely, a lobulated pleural mass along the anterior medial pleural surface. CT scan in this case confirms the presence of an anterior mediastinal mass as indicated by the red arrow, which proved to be Hodgkin lymphoma. The black arrow points out the left lower lobe pulmonary artery, which was clearly seen in contrast to the lung in the left upper and left lower lobes, a CT equivalent of a Hilum overlay sign. This is another example of a Hilum overlay sign. There is a mass on the left, very smoothly marginated. Notice again that I can clearly see the silhouette of the left lung vessels through the mass, indicating that it is either anterior or posterior to the hilar structures. Notice in this case, however, that the mass is very smoothly marginated and very well defined through the shadow of the left heart border back to the region of the paraspinal area, as you can see here and here, suggesting that this is likely a posteriorly situated mass. We can confirm that on the lateral radiograph. It's very posteriorly situated, likely a posterior mediastinal mass, although again, perhaps a posteriorly situated pleural space mass could have a similar radiographic appearance. CT scan shows typical findings of a neurogenic tumor within the posterior mediastinum. Notice that it is heterogeneous and there is some extension into the spinal canal. Patient with a mass situated about the right hilum. Notice that in this case, however, the hilar vessels appear to converge into the mass and cannot be seen separately from the mass. This is an example of the so-called Hilum Convergence sign and indicates the presence of a hilar abnormality, perhaps a mass or enlarged pulmonary artery. CT scan confirms a mass in the right hilum, which is intimately associated with the right hilar vessels. Note also subcarinal lymphadenopathy in this patient with small cell lung cancer. Patient with a lobulated mass overlying the left upper hemithorax. I'll cone down on that mass and notice that the superior border of the mass is very well defined above the level of the clavicles. This is an example of the so-called cervicothoracic sign, and this generally indicates a posterior superior localization for the mass, as it is outlined by lung in the superior sulcus of the left upper lobe. So this is most likely either a posterior mediastinal mass or again perhaps a posterior medial pleural space abnormality. Lateral view confirms the posterior location of the lesion. And on CT scan, we see again a lobulated solid mass arising in the posterior paraspinal region. Notice that it is well outlined by lung in the superior sulcus. This is the reason that we can see it defined above the level of clavicle and the reason that we have a cervicothoracic sign. This was also a neurogenic tumor of the posterior mediastinum, in this case a schwannoma. Now in this case, we also have a mass in the upper mediastinum, but notice that as the mass approaches the clavicles, the margins begin to fade. This has been termed by one of my colleagues an anti-cervicothoracic sign. It's the reverse of the cervicothoracic sign in this case, indicating that the mass is likely either in the anterior or middle mediastinum as it merges imperceptibly with the structures in the neck at the level of the clavicles. Notice also mass effect upon the trachea, so this mass is involving both the lower neck and the upper mediastinum. CT scan confirms the presence of a mass. It's very heterogeneous. It's arising from the inferior aspect of the left thyroid lobe, typical manifestation of an intrathoracic goiter involving the anterior and middle mediastinum, resulting in sort of the reverse of the cervicothoracic sign. It's a patient with a well-circumscribed lesion overlying the right upper hemithorax. Notice that the medial border of the mass is very well defined, but the lateral border becomes imperceptible. This is an example of the so-called incomplete border sign, and this generally means that the mass is in an extraparenchymal location, either within the pleural space or the chest wall. Now there is an additional feature here. Notice the pressure erosion along the inferior surface of the rib. That suggests that the lesion is probably arising in the chest wall, and also that it has been growing very slowly over a number of years. CT scan confirms a soft tissue mass in the chest wall. Notice the pressure erosion on the rib on the CT scan. Typical appearance for a neurofibroma of the chest wall, as this was. Patient presented with cough and fever, and the frontal radiograph is frankly somewhat underwhelming. Fortunately, we had a lateral radiograph, and as we scan the spine from top to bottom, we notice that it becomes more opaque inferiorly. This is an example of a positive spine sign. Normally the spine becomes more loosened as you scan from top to bottom. In this case, it's becoming more dense. Now, a positive spine sign generally indicates disease either within the posterior aspect of the lower lobes, the posterior pleural space, or the posterior mediastinum. In this case, it helped direct us to the left lower lobe on the frontal exam, where we could confirm the presence of a left lower lobe pneumonia, first indicated by a positive spine sign on the lateral chest radiograph. All right, let's now turn our attention to signs that suggest a specific radiographic or CT diagnosis. First patient presented with asthma and chest pain, and we can identify streaky gas lucencies along the upper mediastinal border, extending into the neck, the supraclavicular foci, and either into the extrapleural location overlying the apices or resulting in a small pneumothorax. What I want to point out, however, is this linear lucency extending across the mediastinum, paralleling the superior aspect of the diaphragm, as shown in the red arrows. This is an example of the continuous diaphragm sign, which is another finding suggestive of pneumomediastinum. Pneumomediastinum on CT is shown here. We have streaky gas extending up medially along the mediastinal pleura. We have gas surrounding the inferior aspect of the pulmonary artery. But what I want to point out most is on this lateral reconstruction, this complete circle of gas around the pulmonary artery. This is termed the ring around the artery sign, which seen on CT or on plain radiographs, as in this patient with pulmonary fibrosis, is a unique and interesting finding suggesting pneumomediastinum, the ring around the artery sign. Now, this patient presented with vomiting and acute onset of chest pain. I'm going to cone down to the right lower hemithorax, where we can faintly visualize an irregular V-shaped area of gas overlying the lower mediastinum. This is the so-called V sign of Necklerio, which is a finding of pneumomediastinum, but in a unique appearance and location, which in the appropriate clinical setting is suggestive of esophageal perforation. On CT in this patient, we can see gas surrounding the distal esophagus and infiltrating the mediastinal structures along the superior aspect of the diaphragm, a little bit posteriorly here. And it's this collections of gas along the distal esophagus that give rise to the so-called V sign of the Clerio. In this case, the esophageal perforation was confirmed by barium esophagram. Patient who had just recently undergone thoracic or actually cardiac surgery. This was their first postoperative film. Notice that the lateral margin of the diaphragm appears to be more sharp, more lucent, and deeper than the contralateral sulcus. This is, of course, an example of the so-called deep sulcus sign, which is a finding of pneumothorax in the lung bases in a supine patient. And see, 10 hours later, the patient has a much more substantial pneumothorax, which then required chest tube drainage. Another example of a deep sulcus sign, this on the left, much more dramatic, very deep lateral costophrenic sulcus. Notice the lucency overlying the diaphragm, and very faintly visualize the pleural line in this case, which is pointed to by the fact that we have such a deep lateral costophrenic sulcus. A more subtle example, this also a first postoperative film. In this case, the sulcus is not so much deep as it is more sharply marginated than its contralateral cousin. And notice the relative lucency overlying the right diaphragm and right upper quadrant here. These findings suggest the possibility of a basilar pneumothorax. If you weren't sure, you could try getting an upright film, but an intubated patient, that may not be practical, so then you might request a decubitus radiograph. Another patient, first post-op film after aortic valve resection. Notice that overlying the left upper quadrant, it seems to be more lucent. Here, not particularly a deep lateral costophrenic sulcus. Did not readily appreciate a pneumothorax on the frontal radiograph. But what I want to point out is this lobulation along the left heart border. It's lobulation you don't normally see on supine radiographs. This has been called the floating cardiac fat pad sign. And what these are tags of epicardial fat which are elevated and more sharply defined by the air within the pleural space. And this is another more recently described finding of basilar pneumothorax, the floating cardiac fat pad sign. Okay, and here they were 10 hours later, now with a much more substantial pneumothorax requiring tube thoracostomy. Spine radiograph, this was in an emergency department patient. Notice this unusual dome-shaped lucency over the middle aspect of the upper abdomen. This has been called the cupola or cupola sign because it resembles a dome of air sitting over the upper anterior abdomen. And this is a finding on supine chest radiographs that suggests pneumoperitoneum. It turns out that when patients are in a supine positioning with pneumoperitoneum, it will often collect medially and superiorly under the central aspect of the diaphragm rather than in more characteristic lateral subdiaphragmatic locations. So you see this cupola sign, think about the possibility of a pneumoperitoneum. In this case, an abdominal radiograph was obtained which confirmed the free air under the central portion of the diaphragm. Patient with a classic example of right upper lobe atelectasis, a characteristic wedge-shaped opacity with elevation of the right hilum, etc. But notice also the inferior bowing of the fissure, as illustrated by the second red arrow, and this is an example of the so-called reverse S sign of Golden. And what that generally means is that there is an endoluminal and extraluminal mass causing the right upper lobe atelectasis. So it generally indicates the presence of an underlying neoplasm, which can be confirmed on CT in this patient with a non-small cell lung cancer resulting in right upper lobe atelectasis. Notice the size of the mass and that there is both an endoluminal and extraluminal component. If I compare and contrast right upper lobe atelectasis secondary to a large central cancer resulting in an S sign of Golden to that of right upper lobe collapse caused by mucus plugging where there is no central mass and no extrabronchial extension of that mass, tends to have a more curvilinear shape or sometimes a more abruptly triangular shape. But it is this lateral inferior bowing of the fissure would suggest the presence of the central obstructing mass and the reverse S sign of Golden. Patient with a hazy opacity overlying the left hemithorax, apparent enlargement of left hilum, some volume loss, but of course we quickly identify this characteristic lucency along the aortic arch looking very much like a sickle. This is the Luftsichel sign, or air sickle in German, which is most often associated and seen in the setting of left upper lobe collapse or left upper lobe atelectasis due to an endobronchial mass. See on the lateral view the anterior displacement of the major fissure with the opaque left upper lobe in the retrosternal region. CT scan confirms the presence of a central mass, as you can see here, but the red arrows point to the insertion of the superior segment of the left lower lobe between the collapsed left upper lobe and the proximal descending aorta. So this is the superior segment of the left lower lobe inserting itself between the collapsed left upper lobe and the descending thoracic aorta. And it is this insertion of air which results in the characteristic Luftsichel sign on chest radiographs. So patient with a right-sided Luftsichel sign, it looks a little bit different. It's perhaps not quite as sickled shaped. Notice the large right hilar mass, the vague opacities consistent with right upper lobe collapse. But this is a right-sided Luftsichel sign, seen much less commonly on the right than the left. Okay? And so here the patient in a coronal reconstruction from the CT. Here is the interdigitation of the superior segment of the left lower lobe between the right lower lobe between the collapsed right upper lobe and the mediastinal structures, resulting in a right-sided Luftsichel sign. Notice also the inferior bowing of the fissure seen here, right, consistent with the reverse S sign of Golden, due to this very large central obstructing mass. This is somewhat of a confusing radiograph at first glance. There seems to be a retrocardiac opacity, but there is also an opacity along the upper mediastinum, and it's tempting to look at this case and think the patient perhaps has right lower lobe atelectasis and perhaps right upper lobe atelectasis as well. In fact, this represents the anterior mediastinal fat. This is the anterior junction line, which is being shifted across the mediastinum with herniation of the anterior aspect of the left lung across. This has been termed the upper triangle sign, was described by Dr. Catan a number of years ago, and is sometimes known as the Catan triangle sign. And the usefulness of this sign is that it always points to the side of the lower lobe collapse, which is down here. So if in fact you didn't identify this at first, you just saw this, you see that triangle sign pointing toward the right, you look more carefully for the presence of an atelectatic right lower lobe. On the CT scan, we can see the atelectatic right lower lobe, and we can see the mass obstructing, in fact, the bronchus intermedius here. The patient also had some degree of right middle lobe atelectasis as well. Here's a series of radiographs on a patient. On the initial film, looks relatively normal. On a follow-up film 24 hours later, has a chest tube in, has been trached. There's increased opacity in both lower lobes, but particularly on the left. But what I want to point out is the presence of a triangle sign, in this case pointing toward the left. Here's the anterior junction line, which is being displaced toward the left. Here it is in normal position, suggesting that most of the opacity we're seeing in the left lower lobe represents atelectasis, perhaps secondary to aspiration. So the triangle sign very useful, as it is a signpost toward lower lobe atelectasis. Patient with chest pain, and this chest radiograph showing bilateral subpleural opacities, which are relatively well defined. They have broad bases against the pleural surface. They are roughly triangular or wedge-shaped, and these, of course, are very characteristic of so-called Hampton Hump, or in this case, Hampton Humps, right? Which generally suggests the presence of pulmonary infarction due to pulmonary embolism. These are Hampton Humps on CT. Notice that they're often broad-based, they're often truncated, you may see a vessel extending to them, and they often contain these unusual central areas of bubbly lucency. We'll discuss that in a little bit more detail later in the lecture. Here is the mediastinal window showing the large emboli in both lower lobes. Hampton Hump secondary to pulmonary infarction. Another patient presents with chest pain and circulatory collapse. Notice the relative lucency of the left hemithorax compared to the right. This is an example of a Westermark sign, which is seen in patients with large central pulmonary emboli, as you can see on the PECT examination. Another patient with, I think, a Westermark sign on the right, an area of relative oligemia. But also notice the abrupt enlargement of the right hilum. The right hilum seems to be both enlarged, and the vessels leading from it seem to be somewhat truncated. And this is an example of a so-called Fleischner sign, abrupt enlargement of a central pulmonary artery secondary to a large obstructing central pulmonary embolus, as you can see on the CT angiogram in this particular example. There are a number of signs on chest radiographs which are seen in patients with pulmonary embolus. This includes the Hampton Hump sign, Westermark sign, and Fleischner sign. It should be remembered, however, that the most common abnormalities in patients with pulmonary embolism are linear bands of atelectasis and small pleural effusions. All of these other signs are quite unusual. The reverse CT halo sign or reverse halo sign is a sign which is seen on CT, and we will discuss that later on in the talk. Patient a few days after a median sternotomy for bypass grafting. Here they are 5 days later. Notice what's happening to the wires. The inferior wires are moving to the left, the middle wire has moved slightly to the right, and the upper wires have remained midline. This is an example of the so-called wandering wire sign, which was described by Dr. Boiselle a number of years ago. And when you see the wires begin to wander, you have to be concerned about the possibility of a sternal dehiscence. And in this case, in the reconstructed images, we can see that the inferior 3 wires have gone with the left half of the sternum. There's a very broad-based dehiscence. The middle wire has stayed with the right half, and the upper 3 wires are sort of straddling the fence in the manubrium as they're trying to hold it together. So the wandering wire sign, a sign of sternal dehiscence on chest radiographs. Patient presented to the ER with shortness of breath and an unusual configuration for the cardiomediastinal contours. It looks like cardiomegaly, but it has a somewhat unusual shape, looking very much like a water bottle. And this is the water bottle heart sign, which is a sign suggestive of pericardial effusion. Lateral radiograph in this individual shows another sign of pericardial effusion. Notice the separation of the epicardial and pericardial fat stripes by this soft tissue stripe, which exceeds 2 millimeters in diameter. That is a very specific finding for pericardial disease, either pericardial effusion or pericardial thickening. This sign has been termed variously the epicardial fat stripe sign, that was the first name, but is also sometimes known as the sandwich sign or the Oreo cookie sign. And again, separation of that pericardial stripe by the epicardial stripes by this pericardial and epicardial fat stripes of greater than 2 millimeters is highly suggestive of pericardial disease. And here's the CT confirming a very large pericardial effusion. Okay, Let's now discuss signs that are useful for suggesting a limited set of differential diagnostic possibilities. This is a patient with severe asthma that has branching tubular opacities in the right upper lobe. This is a classic example of the so-called finger and glove sign, and you can see why, which is indicative of large areas of mucoid impaction. You can see this on the chest CT as well, where we have these large dilated areas of mucus in the right upper lobe, a finger and glove sign on CT scan. Now, the differential diagnosis for mucoid impaction on chest radiographs or CT include allergic bronchopulmonary aspergillosis, segmental bronchial atresia, an endobronchial mass, other forms of bronchiectasis, including cystic fibrosis, and sometimes mucoid impaction is seen in run-of-the-mill asthma. And there are other things on the differential diagnosis. These are probably the 5 most common, particularly when the mucus plugs are quite large, as in this particular case. This is a patient with allergic bronchopulmonary aspergillosis, whereas large mucus pluggings is one of the hallmarks or radiologic keystones for diagnosis. Patient with cough and wheezing who also has dilated airways and mucus in the right upper lobe. Notice the background of emphysema. This was an older patient who was a smoker. CT scan in this case confirms the presence of mucoid impaction in the right upper lobe, but also reveals a central obstructing mass, a lung cancer. So you see large areas of mucoid impaction confined to a lobe or a lung in a older patient, a smoker, a patient with emphysema. Think about the possibility of a central obstructing neoplasm. Patient with neutropenic fever develops rounded areas of consolidation as shown on this chest radiograph. CT reveals an unusual configuration. So these rounded areas have these central well-defined areas of soft tissue opacity with a surrounding zone of ground glass attenuation opacity. This is an example of the so-called CT halo sign. Now, the differential diagnosis for a CT halo sign includes angioinvasive fungal pneumonia, particularly invasive aspergillosis, where the sign was first described by Dr. Kuhlmann a number of years ago. Subsequently, it has been described in patients with hemorrhagic metastatic disease, such as from renal cell carcinoma, in cases of adenocarcinoma with lipidic growth pattern around a central area of invasive adenocarcinoma, in patients with vasculitis such as granulomatous polyangiitis, and a variety of other conditions. These are 4 that are worthwhile remembering. This patient with neutropenic fever proved to have invasive aspergillosis, and in fact, in that clinical setting of neutropenia with fever, a CT halo sign is highly suggestive of angioinvasive fungal pneumonia, likely aspergillosis, but a similar pattern can be seen in patients with pulmonary mucormycosis as well. Patient with neutropenic fever also developed a nodular area of consolidation superimposed upon the right hilum. Notice on CT scan a characteristic CT halo sign suggestive of invasive aspergillosis. 5 days later, we see progression with increasing consolidation in the right lung, and at 10 days, near complete opacification of the entire right lung. Patient was actually having severe hemoptysis at this time. What I want to point out, however, is that the patient has developed this unusual crescent of lucency where that central area of nodular opacity was. This is an example of the so-called air crescent sign on chest radiographs. Now, the differential diagnosis for an air crescent sign again includes angioinvasive fungal pneumonias, principally invasive aspergillosis or mucormycosis, and again in the setting of neutropenic fever is highly suggestive of that diagnosis. It can be seen in patients who have mycotomas that develop in pre-existing cavities. That's more properly called the Mucoid sign, as we will discuss in a minute. It can be seen in other cases of necrotizing infection. I've seen it in patients with strep pneumonia infection, for example. Vasculitides, I've seen it in patients with granulomatous polyangiitis, cavitary neoplasms, and the like. And again, there are other things on the differential diagnosis, but these 5 possibilities are worthwhile remembering. This patient had invasive aspergillosis and, in fact, developed severe hemoptysis that led to her demise. A patient with a thin-walled cavity in the right upper lobe. This cavity was secondary to prior M. kansasii infection. 2 years later, she presents with hemoptysis and an intracavitary mass in the dependent aspect of that cavity. Notice that on prone and supine CTs that this mass is gravity dependent, so it's a mobile mass within the cavity. This is, of course, a mycetoma that is developed in this cavity secondary to previous M. kansasii, most likely aspergillus, but other fungi sometimes cause mycetomas. And this particular sign is called the Mucoid sign, and that specifically refers to the development of a gravity-dependent mass within a pre-existing cavity. So there are a number of signs which are associated with aspergillosis. The CT halo sign and the Crescent sign are associated with invasive aspergillosis. The CT halo sign is a relatively early sign and is therefore often helpful for suggesting the diagnosis. The Crescent sign is a sign which is seen late in the course of the disease, usually during the period of neutrophil recovery, and this is not all that useful for suggesting the diagnosis. A mycetoma may develop in a pre-existing cavity that is called the Mucoid sign. And then, as we discussed earlier, in patients with allergic bronchopulmonary aspergillosis, you may see the characteristic finger and glove sign indicating large mucoid impactions. Because there is a fair amount of confusion between the Crescent sign, which is sometimes seen in patients with mycetoma, and in patients with invasive aspergillosis, I just want to highlight and emphasize the differences. So with a mycetoma, the lung begins with a cavity due to another cause. Over a period of years, fungus begins to grow within the cavity, often at the lateral and superior margins of the cavity, which can result in apparent cavity wall thickening on radiographs or a pleural reaction along the superior and lateral aspects of the cavity. Then again, over a period of years, the fungus may condense down within the cavity and form a gravity-dependent mass within the dependent aspect of the cavity, which then, if we put the patient in a decubitus position, prone and supine positioning on CT, we can see that this is a gravity-dependent mass. And this whole process, is termed the Mucoid sign, more properly termed, although it's sometimes referred to in the literature as an Crescent sign as well. Now, in invasive aspergillosis, the lung is initially normal. The patient becomes neutropenic and over a period of days develops these nodular areas of consolidation within the lung, which on CT manifests with this characteristic CT halo sign. And then as the neutrophils recover, the patient may develop cavitation, forming an Crescent sign, as you can see here. Now, these Crescent signs, or I should say these masses within the cavities, generally are necrotic lung rather than true mycetomas, and they're often adherent to the wall of the cavity, so they're usually not gravity dependent. But superficially, this lesion can appear as a mycetoma, and it's only by looking at previous radiographs and knowing the clinical history that we can accurately distinguish between an Crescent sign seen in late invasive aspergillosis or other angioinvasive fungal infections from a Mucoid sign due to saprophytic colonization of a cavity. Patient presented with dry cough and dyspnea and had several of these lesions, one illustrated in the right lower lobe, characterized by a central area of ground glass attenuation opacity and a rim of higher attenuation. This is the so-called reverse CT halo sign, or more properly, the reversed halo sign. It is called that because it is the exact reverse of the CT halo sign. So here's a CT halo sign in a patient with invasive aspergillosis. Here is a reversed halo sign in a patient with organizing pneumonia. And you can see that in the reversed halo sign, we have the central area of ground glass with the peripheral area of soft tissue attenuation, exactly the reverse of a CT halo sign. Now, the differential diagnosis for reverse halo includes organizing pneumonia, in which it was first described, but also includes mucormycosis and other infections, vasculitides, adenocarcinoma with a lipidic growth pattern centrally, pulmonary infarcts, and cases of sarcoidosis. And in fact, the list is quite long, and this article by Dr. Marchiori lists a large number of causes, but if you remember these 6, you will be in good shape. This was a patient with cryptogenic organizing pneumonia, which is organizing pneumonia, of course, without a known cause, which is a very characteristic cause for this reverse CT halo sign or reversed halo sign. Now, I mentioned pulmonary infarcts on CT earlier as having a very characteristic shape and a characteristic internal lucencies, and to some degree, these can look like a reversed halo sign on CT. However, in patients with infarcts, the central areas are often not homogeneously of ground glass attenuation, but demonstrate these sort of bubbly central lucencies, often looking like a stool-filled colon, and sometimes it's been called the pseudocolon sign as well, but it is included in the differential diagnosis for reversed halo sign. Now, I should point out that the reversed halo sign is also known as the Atoll Sign in the literature because they resemble atolls in the South Pacific, but the current preferred term is the reversed halo sign, as is pointed out by Dr. Marchiori's article. Now, this patient presented with cough, and I'm just going to let the CT run for a couple minutes here, or a couple seconds. Notice that the CT is characterized by numerous centrolobular nodules. Why centrolobular? Well, they're occurring out peripherally at the center of the secondary pulmonary lobule, but they do not touch the pleura. Notice that there's about a 5 millimeter clear zone between the nodules and the pleural surfaces. So these are centrolobular nodules. But note also that in addition to nodules, there are branching linear passages which are larger in diameter than the core lobular arteries, which tend to connect many of the small nodules, giving this a tree in bud appearance. And this is an example of a tree in bud sign on CT, given that name because it resembles very much trees budding in the spring with the branching tubular opacities extending to these small nodules out at the center of the secondary pulmonary lobule. Now, the differential diagnosis for tree and bud on CT includes infections and a wide variety of infections: tuberculosis, non-tuberculous mycobacterial infection, bacterial and viral airways disease can manifest with tree and bud opacities, aspiration, particularly if the tree and bud opacities are in a dependent location. And in a recent review, infection and aspiration accounted for over 75% of causes of tree and bud on CT, with infection by far the most common cause. Other things that can cause tree and bud: any cause of bronchiectasis with distal mucoid impaction can manifest with tree and bud opacities. You can get hematogenous metastases that simulate a tree and bud appearance on CT. IV talcosis, that's injection of drugs cut with talc or cellulose material, can cause a granulomatous vasculitis and pneumonitis that simulates the appearance of tree and bud on CT. And even sarcoid on occasion can have a tree and bud appearance. This was a case of viral bronchiolitis, in this case adenoviral infection, manifesting with tree and bud opacities. A patient with chronic dyspnea. In this case, we have geographic areas of ground glass attenuation with superimposed areas of thickening of intralobular and intralobular septa interspersed with a few areas of normal lung. This is, of course, a crazy paving sign or crazy paving pattern on CT, so named because it appears as or simulates the appearance of cobblestone paving, which is called crazy paving in some parts of the world. Now, there is a differential diagnosis for a crazy paving pattern or sign on CT, which includes alveolar proteinosis, the condition in which it was first described, but also includes adenocarcinoma with a lipidic growth pattern, exogenous lipoid pneumonia, pulmonary drug toxicity, alveolar hemorrhage, pulmonary edema, and the list goes on. But if you remember these 6 causes, you will be doing very well. This was a patient with alveolar proteinosis, which very classically manifests with the crazy paving pattern on CT. Another patient with a localized crazy paving pattern, localized to the right lung. A very nice example. We have lobular areas of ground glass. We have thickened interlobular septa, a few intralobular septa that are thickened as well as normal areas of lung. A very nice crazy paving pattern. In this patient, localized to the right lung, and on biopsy, this was adenocarcinoma with a lipidic growth pattern. So we have covered in this talk some signs that are useful for localization of abnormalities on chest radiographs. We have discussed a few signs that suggest a specific diagnosis, and we have discussed a few signs that are suggestive of a limited set of differential diagnostic possibilities. Obviously, we've only hit the highlights. There are many more signs that we can discuss. However, this sign tells me it's time to stop. I will leave this up for just a minute. These are some additional references in additions to those cited during the talk, which you may find helpful for further reading. And at this point, I will stop and thank you for your attention.